Welcome to the 5th Disability Research and Education in Academic Medicine, or DREAM Grand Rounds, Research Rounds. My name is Lisa Meeks, and I'm the Executive Director of the Docs with Disabilities Initiative. As you may know, DREAM Consortium is part of the Docs with Disabilities Initiative and is focused on 4 areas: to create, mentor, and grow a robust community of scholars focused on advancing disability inclusion, research, and academic medicine. Second, to highlight and promote research on disability inclusion in academic medicine. Third, to identify and address gaps in disability data in academic medicine. And finally, to connect researchers and stakeholders to promote cross-cultural collaboration. Today, we have the pleasure to introduce our speakers who will present on the policies as barriers for disabled medical learners, an exploratory study of learners' perspectives. And first, I get to introduce someone who's very special to me. Dr. Pamela Liao is an assistant professor at the University of Toronto. Her clinical practice is focused on rehab, geriatrics, and palliative medicine. She's lived an experience in seeking accommodations during her medical training. She serves on the board of the Canadian Association of Physicians with Disabilities and shared the pleasure of working on the social media campaign with me. And indeed, I remember, and Pam and I were just talking about just 2 people that are really passionate about this work, chatting. This is back during my fellowship, chatting about what we could do to elevate the knowledge about people with disabilities. And so many of you will not know this, but Dr. Pam Liao is the co-creator of the hashtag Docs with Disabilities and the media campaign. And it's just such a pleasure to just think and grow with her and those ideas. Dr. Battalova holds a PhD in disability studies from the University of Illinois at Chicago. Her research areas include sociology of health and disability, disability advocacy, community-based research, program evaluation, and qualitative research methods. She currently works as an evaluation lead in mental health and substance use services in Vancouver, British Columbia. And without further ado, I will turn it over to you, Dr. Battalova.
Thank you so much, Lisa. It's very nice to be here today and very nice to co-present with Pam. Let me just share my screen. Okay. So before we begin our talk, I would like to acknowledge that I'm joining you today from the traditional, ancestral, and unceded territory of the Musqueam people, colonially known as Vancouver. Our team realizes that oppression is oppression, and the work of of the inclusive campus lab that I'll be talking about focuses on expanding our understanding of justice and the application of the justice lens to include race and indigeneity. According to the 2017 Canadian Survey on Disability, Indigenous people were more likely to have 1 or more disabilities than non-Indigenous people. Decolonizing disability requires both an acute awareness of colonial processes that contribute to and cause disablement, as well as a deliberate attempt to remove these structures from our social organizations. This is an image that was created with elders who participated in our project. The image summarizes the barriers that Indigenous people face in healthcare settings. The intersections between disability and indigeneity generates knowledge rooted in Indigenous and disability lived wisdom, and creates new ways of knowing and relating to others, to place, to the past, and present. And the image also reflects the storytelling traditions of Indigenous people. So our outline for today is I will first speak about, as I mentioned, inclusive campus. So it's a broader context in which the study that we conducted took place. We will also discuss the methods that we use, the themes that were generated, and recommendations. So Inclusive Campus is the project that is part of a network of international collaboration for inclusive campus. And it's led by Professor Tal Jarrus from the University of British Columbia, Department of Occupational Science and Occupational Therapy. Professor Jarrus has been a true leader who built a team of researchers and allies whose passion for the work started moving the needle on inclusion of people with disabilities in health and human service workforce. And our team brings together researchers from different countries and different disciplines, including medicine, nursing, occupational therapy, physical therapy, social work, and even teacher education. And I joined the project around 2017 and was really privileged to work and learn from this incredible group of people. The Inclusive Campus Initiative started around 2012 and included a few milestones. So in 2012, we embarked on an exciting journey of not only conducting a large-scale research project, but also translating the findings and mobilizing the knowledge to effect change. Each of the subsequent steps were informed by the previous one. For example, we developed workshops and a range of resources for students in health professions. And the content of these workshops and the resources, they were informed by the findings of the grounded theory study that we conducted. In the interest of time, I will highlight a few of these milestones. Over the years, our work was supported by several funding agencies. So the grounded theory that I mentioned earlier, it's a central component of Inclusive Campus, and it was based on a qualitative study, the interviews with 27 students and 29 practitioners from 5 health and human service fields. The project investigated the barriers and facilitators of individuals with disabilities to study and practice in the health and human service disciplines. And the reason why we undertook this approach and decided to develop the study this way is that the understanding at the time of the topic remained descriptive, fragmented, often included only one health profession, excluded particular types of disabilities, and focused on maybe one aspect of the career journey. And we offered a more complex approach to this topic, and also that allowed us to bring in some lessons from a variety of disciplines, and also introduce legislative, educational, practice systems. So very kind of complex approach to the topic that was not necessarily there before. The study recognized the tensions between intentions for change in addressing equity issues and the realities and demands of day-to-day practice and the struggle in balancing various dynamic forces that are central to promoting inclusion. And so this is the image from that basically summarizes the findings from the grounded theory study. Again, I will not go into too much depth on this. I did provide a reference at the bottom of the screen, so you can certainly read more in that article that was published recently, but just wanted to highlight a couple of things that we learned. So we learned that participants experience challenges to their sense of legitimacy and belonging as health providers. They describe tensions within the health education and practice between the commitment to inclusion and like I mentioned, realities of day-to-day life. We identified 6 distinct but very related conditions underlying these tensions: validity and transparency of competencies evaluation, the social and physical contexts, integration of inclusive practices, boundaries between personal and professional identities, vulnerability to authority figures, and finally, dynamic person-level factors. So things, for example, related to when an individual acquired a disability. Just a couple more points. So, and improving legitimacy indeed can be viewed as a fundamental task for all health providers. The norms that underlie beliefs, interactions, and practices can be experienced by students and practitioners with disabilities as unreasonably inflexible and judgmental. And this compromised sense of legitimacy and belonging extends to participants' perceptions about their potential and capacity to perform professional skills, to navigate health-related social interactions, and to elicit trust from colleagues and care recipients. So this is just, again, examples of some of the publications that came out from that main study. So as I mentioned, the main summary of the study is published in Medical Education. As well, we have an article that I led in Qualitative Health Research, and that focuses on understanding how clinicians' disability experiences shape their interactions with clients. So happy to talk about that more in Q&A. And the next sort of milestone that I would like to emphasize is the workshops. Again, workshops were based on the findings of that research. So we developed a series of workshops for students that focused on disclosure, transition to the workplace, advocacy rights and responsibilities, and accommodations in clinical settings. The resources that we developed included such tool as a disclosure matrix that helps students evaluate the benefits and detriments of disclosure. We also developed online modules that are coincidentally also called the DREAM, just like this research rounds. And the DREAM stands for Disclosure, Rights and Responsibilities, Advocacy and Accommodation modules. It's a skill-based blended learning module that has several components like online modules. Then individuals can also answer some reflective questions while taking the module, watch some videos, and complete other activities. Another exciting piece of work that was done under the Inclusive Campus umbrella is this knowledge translation project, and it's research-based theater. The title of the play, Alone in the Rain, referred to something that one of the participants shared with us when describing their struggle when navigating barriers of being a clinician. Research-based theater was employed as a tool for effective learning, including increased empathy for people with disabilities in health professions. Using moments of humor and conflict, this play dealt with external and internal stigma about students and clinicians with disabilities and their sense of belonging. The stories of 4 different characters were shared by way of creative monologue. And in these monologues, different theatrical conventions were used to externally represent the experiences of these characters, each living with a different form of disability. The first iteration was a 10-minute long play and used collaboratively created vignettes, tableau, and a song about stigma to draw audiences into deeper affective understandings of the experiences of students and clinicians with disabilities. I also provided a reference to a publication about that. And I know Dr. Jarvis mentioned that The play will be available very soon on the online platform Tapestry. If any of you are interested, I'll provide an email at the end of the presentation, and you can certainly reach out about that. We also did an evaluation of the play, and these are just a couple of comments that we heard from our listeners, from the viewers as well. So, but basically, yeah, they all mentioned how much impact that experience made for them. So it was well received and demonstrated a truly transformative potential of theater. We also created handouts, one for clinicians with disabilities, one for allies, and one for creating accessible presentations. So I will also share, I provided QR codes on the screen, but I will also share the links, direct links to them at the end of my presentation. But all in all, this work resulted in quite a few products. So we had several versions of the play, more than around 18 conferences, 36 performances, and a total of about 2,000 people were reached through this work. I will now hand it over to Pam to talk more about the actual study that was part of Inclusive Campus. Over to you, Pam.
Thank you. Okay, so first step is to see if I can move the slides. Or you're going to do it?
Oh, yeah, I can do it.
Okay, perfect. So just going back to the beginning, I wanted to say a special thank you to Lisa for such a warm and wonderful introduction. I think one of the main takeaways I've had from this whole experience is just the opportunity to build a sense of community. And so I think it's so important to, pardon me, have opportunities like this to come together and to see all the incredible work that's happening. So this project was really born out of my own experience and reflection of clearly the process was not what it should be, and how can we change that discourse. And so this actually is several years now that the project happened, and it's surreal because COVID seems to have been the last decade of our lives, but this was very much before then. And so I had put together a proposal and then reached out to some of my mentors where I trained at the University of British Columbia and was connected with Dr. Battalova as well as Dr. Yaris, and that's how this project came together. So as well, thanks to them for really helping me to see this through, because truthfully, I haven't been in touch with this work in so long. All the COVID outbreaks and the militaries coming into nursing homes and hospital crisis has really been my world for the last 3 years. So to come back to this is also just very rejuvenating. I did want to mention I have only one disclosure, and that is that I serve on the board of the Canadian Association of Physicians with Disabilities. And with that, I'll move forward. Thank you so much, Alfiya. So I think the main point of presenting this data today is to really capture the richness of the interviews we had as part of this study. It became very clear the themes that emerged, and they really align with a lot of the work that's already been discussed. And so I'm not here to come and really share my experience, but really to be a conduit for the voices that we heard in the study. And I think and I recruited most of them personally, I think their hope being in the profession and having the challenges that they did was to, by sharing their stories, really affect change. So I really appreciate the opportunity to do that today. Just to be clear, the asterisk indicates that all the names and identifying information have been removed, but the essence of the stories is still very much present. So, oh, sorry, just go back and I'll share that. The system is bureaucratic. One person said, go to this person. Another person said, well, go back to the first person. And they kind of kicked me around like a ball. And at the end, they said, well, we just don't have enough time to make those arrangements, even though I did contact them on the first possible day. Inefficiency, bureaucracy, nobody is really in charge of making that decision, and nobody really does much. Next slide, please. So just to give context, this is now somewhat dated information, but in a way, I think it is helpful to capture what was happening at the time that the study came across. Definitely there was dialogue, and people like Lisa Meeks were starting their research projects and advocacy work around this time. But I did highlight a few Canadian stories just to kind of give context, because I know this is an international forum. And so there had been at least 2 legal actions by trainees advocating essentially for their rights to access accommodations. And some of that is highlighted here. Next slide, please. I'm sorry, I don't have the context for this slide. I can't see the background, but I think essentially, and this has been discussed before, is just that there is an underrepresentation of healthcare providers, especially in the health professions, education programs, compared to those who would identify with a disability in the general population. And so I think hopefully through this work and many others, we can begin to understand what those barriers might be and how to address them. Next slide, please. So in terms of meaningful accommodations to support learners through their educational experience, there's a number of components that we kind of recommend that be a component of. Principles such as timeliness, which you heard about in that quote, being proactive. Again, this learner was struggling and trying to be the one to initiate, but really that should be coming from an institutional level. Confidentiality, which I think is pretty self-explanatory. And of course, underlining principles of equity. Next slide, please. So in terms of the methodology of the study, we initially did an analysis. We collected the policies, if any, from all the major accredited medical schools in Canada, which compared to the US was not such an insurmountable number, and I think is an interesting comparison and opportunity, which we'll touch on in the future. After we synthesized this, we provided it to the respondents in the study and then had them comment, and then we aggregated themes from those interviews. Next slide, please. So going to our first step of reviewing the policies, we looked at every Canadian program. Each of them had a number of opportunities for accommodation that was quite clear at the pre-clerkship level, which tends to be didactic in the classroom and mirrors what you would see in many other undergraduate or graduate type programs. But where it really became unclear and less consistent was in the clerkship years, where trainees were on the wards with patients, and it was very varied because you could be in a clinic, you could be in the operating room, you could be in the emerge department, this type of thing. And so of the 14 schools that we looked at the time of the study, 4 had a specific accommodations office housed within the Faculty of Medicine, who arguably could be better equipped to tackle those more clinical learning environments as opposed to the didactic setting, which was often accommodated through the general kind of university broader programs. And most of the students in these policies effectively managed each of these students in a case-by-case manner. So there wasn't sort of a consistent step 1, step 2, step 3 type process. Next slide, please. This is just to summarize kind of more specifically the findings. And I think really, if you just look at the bottom, it's looking at the type of learning environment, whether that be from an evaluation perspective, like exams, whether they be written or with mock patients or kind of in a lived scenario, versus different types of learning environments. And you'll see that the numbers are really quite varied. Next slide, please. This is just an image to capture the themes that really came across from our interviews with the learners when they were able to review our summary of the policies: inconsistent, fragmented, bureaucratic, marginalized, contradictions. Next slide, please. So this is just to capture the major themes that came across from the interviews. And so I'll highlight them here. And then what I'll do is, again, going back to the participants and kind of getting into putting some color on this in terms of what their experiences were. And again, captured in the infographic you just saw. Bureaucracy is a barrier. difficulties in navigating the system, power dynamics, and negative perceptions within the profession of medicine. Next slide, please. So under the theme of bureaucracy and being fragmented, this notion of I was footballed around, Dan shared with us, I couldn't believe it. Nobody really knew the whole sort of framework. If there was one person at the institution who knew the framework and sort of sat down and helped you, it would have been a much, much easier process. So identifying the need for support around navigation. Next slide, please. Bureaucracy being contradictory. So Eric shared with us, well, I knew the answer from the policy. Their answer in response to me was completely against the policy. They said, well, no. And I think this also speaks to awareness of policies being in place, but that the broad range of faculty and staff being aware of it. Next slide, please. The next theme was navigating the system. And one of the captions was, I'm left on my own. Fran shared with us, I just didn't know what was on the menu for help. I was never offered an accommodation. I felt like I fought for every step of that. So really leaving the burden on the learner to navigate this entire experience. Next slide, please. Other messages that came across were taking the initiative, fighting every step of the way, having to keep track, doing a full-time job of seeking accommodations while also being a full-time learner, as well as managing their health needs, having to propose the solution, and having allies. Next slide. The third theme was power dynamics. We are really in a powerless situation. From the interviews, we were able to identify that there were both short and long-term negative consequences simply in the act of seeking accommodations. Brad shared with us, we're really in a powerless situation. It's a cost-benefit analysis anytime I do anything. It might be better in my health in the long run to not take overnight call, but if it's going to interfere with CARMS, which is essentially our match program and how applicants seek residency spots, like, do I just want to take the bullet? So Brad's grappling with doing what's best for his health and his needs versus feeling conflicted with this need to be competitive in order to proceed from a career perspective. And so one of our recommendations was to have advocates who are detached, separate from the evaluation process to really help navigate the experience of seeking accommodations. Next slide, please. The fourth theme was negative perceptions. They don't want disabled doctors. Dan shared with us, doctors are not good at helping other doctors with these types of problems because they're part of the culture. Throughout the interviews, there was themes around paternalistic and discriminatory attitudes. When disability was acquired, also played a role. So one of the interviews one of the interviewees felt that if somebody came into the profession with a disability, they were perceived differently than somebody who acquired the disability later on in their career, whether that be in the midst of their training or even afterwards. And it's not listed here, but essentially the sense that if somebody were to acquire a disability once part of the profession, they were more cared for and included than somebody who began the journey into the profession with a disability that they identified. And I think this just overall speaks to the role of representation. Next slide, please. So taking in the richness of these interviews, and we've only truly skimmed the surface. So I really do encourage you, if you are interested to hear more of these narratives, to access the article, which we provided the reference for, and I'm sure the slides will be available later. Our team came together with really taking forward the messages and putting them into recommendations. And so I'll just highlight some of those key themes here. And they're in no particular order. So the first is cultural shift. And this starts at the beginning to change the narrative and identity of what a physician looks like. And this comes from recruitment and admissions. And at least in the Canadian context, there have been successful models in terms of trying to increase diversity. So where I did medical school at the University of British Columbia, there was a highly successful First Nations recruitment program. And that was then the model to launch the BKSAP. Sorry, I cannot remember the acronym at University of Toronto, but effectively to recruit Black medical students, which again has been quite successful. Their numbers have really shown a marked improvement with recruitment, but also these programs provide support to those learners while in the program. So models exist. And also workshops for students, faculty, and staff, so that we cover, again, not just the recruitment and bringing diverse populations into the profession, but then how do we support them through their educational journey and on into their careers. The second recommendation was a cohesion of services. So through the interviews, you heard about learners kind of struggling, really isolated, trying to seek out accommodations. And so one of the recommendations or suggestions we came up with is to have a point person, to have a direct liaison that could continue with this learner, rather than, particularly in clerkship where we saw the real gaps, your placements are changing every few weeks, and to re-navigate that conversation each time can be a huge burden, and you're having to explain and start from square one. It might be better to have a dedicated person who sees you through your learning journey and can help anticipate some of those necessary accommodations. And then the other component of really creating that cohesion is to be more consistent and have standards around what minimum standards should be available for a meaningful accommodations program within a university setting. Next slide, please. The third theme was capacity development, and this is really targeting the educators, administrators, and the institutions overall in terms of what their rights and responsibilities are, and increasing education opportunities for that, to allow for adequate resources to be put into these programs so that they can actually have meaningful impact for the learners. And one of the things that came across was that this is a very specialized area and deserves specialized skills and resources. And so possibly the idea or notion of a national center of excellence. So rather than trying to build up the resources within individual universities, have a single program that can really be the hub where all the experts can gather and provide best practices and exchange information. And one of the resources, funny, I was just having a meeting with them yesterday, was that within the provincial medical associations, or PTMAs, there are physician health programs. These programs are really interesting as they were first developed in order to support physicians with mental health and addictions issues continue in practice. But that historical sort of notion has very much changed. And I think just going back to kind of context with COVID, the notion of burnout has become very much mainstay. And so these programs are really there to help support physicians, medical students, residents, fellows, trainees, et cetera, across the career spectrum with their health needs. I think anecdotally, the experience around physical disabilities has not been as strong because it's just not an area they see often enough. But with respect to mental health, they are really well skilled. And so there could be an opportunity here to either improve linkages or to build capacity to help take on this accommodations piece as well. I'm sorry, something's beeping and I don't know how to turn it off. So the last point quickly is to just broadening the scope and defining the problem. So this study was very much focused on medical students at the undergraduate level. However, as we see the transition from didactic to practicum-based learning or clerkships, looking at the experience of residents, fellows, and those in practice who've now finished their relationships with universities and are now out in the real world, so to speak. What are their experiences like in seeking accommodations, because it becomes less clear. Part of the reason we designed this within medical schools was there's a very clear infrastructure, but some of the legal cases that we referred to earlier on came up with ambiguity around residents who are not only students of the university, but also employees. So that creates a lot of ambiguity as to who's responsible So I think there's a lot more work to be done, and I'm really thankful for the opportunity to share this work with you. Next slide, please. I'll just finish with this quote from Gina. They don't know what it's like to be stared at, to be asked what's wrong with you. They just don't know what my reality like and my peers with disabilities do, and a doctor with a disability would. And that's why it would be so beneficial to have somebody who's had lived experience serving that population. I can't emphasize that enough. It makes you more empathetic. It makes you have better understanding, more creative, and in many ways a better person, because you have an understanding of the human condition that better than people without disabilities. And I'm ashamed that's not realized now. Next slide. Just to leave us on a positive note, it is a simple matter of social justice and equity. Our healthcare professional community mirrors society, also with the inclusion of physicians with disabilities. Dr. Jordan Cohen. Next slide. And so we've captured in some of the recommendations kind of future directions, but one piece I did want to highlight is that this is very much Canadian specific data. And so there has been work done to do international comparison between Canadian and US studies. And so I'll just leave it here that if this is of interest, that that's another opportunity to have that comparison be presented at a forum like this. Thank you so much.
This is just some contact information for all of us. Thank you.
Thank you both so much. This is amazing. And I can't help but think there's already so much rich data for a cross-cultural collaboration in the US and Canada, given your findings, which align with our findings so well. And we would love to do anything to help Canadians get the data on the amount of learners and trainees and physicians with disabilities as well. Thank you both so much for contributing to this. I'd also like to thank our funder, the Ford Foundation, for providing the funds to elevate the global work in this area and bring this through the recording to anyone at any time who is interested in your topic, and many will be. We have some questions from the audience, but before we do that, I'm going to ask Richard to stop the recording.